Hello, my name is Dr. Derek Lee. It's my pleasure to introduce spine surgeon, Dr. Sajan Hegde, who's a consultant spine surgeon and head of the Department of Orthopedics at Apollo Hospitals and in Chennai, India. Welcome.
Thank you very much. Derek, it's truly a pleasure to have this conversation with you. It is evening here in India, but a very good morning to you.
Thank you so much. Now, typically I start these interviews with asking the surgeons how they became first interested in medicine, and perhaps talk about the events which influenced you on focusing on the spine in your orthopedics career.
Yes. So as a child, I loved playing with toys that I could build with my hands. And I enjoyed playing with Meccano, Lego, with which I could put together replicas of cars, planes, and trucks, anything that could be mechanized to move. Growing up in a typical middle-class Indian household, it was expected that I excel in academics. This took precedence over everything else, like sports and other extracurricular activities. So getting into medical school was sort of par for the course, though it was extremely coveted and very competitive. Medical school for me was rather an uneventful experience, but I came into my own when I took up orthopedics, when I decided to specialize in orthopedics. I enjoyed setting broken bones together and fixing with metal plates and screws. It was harking back to my childhood memories of playing with Lego and Meccano.
Excellent. Now, I know with respect to your the spine aspect of your career, you underwent training with some very, very excellent, respected surgeons in both France and Germany. Can you talk a little bit about that?
Yes. See, after completing my orthopedic residency, I was a bit clueless what direction to take. As a greenhorn orthopedic surgeon, a chance meeting with Dr. Yves Cottrell, the venerable French spine surgeon, was a life-changing experience. He invited me to France to do a spine fellowship. This, in fact, was the beginning of my long journey as a spine surgeon. I did my spine fellowship at Institut Callot in the Normandy part of Northwest France. I trained under the renowned spine surgeon, Dr. Daniel Chopin. It was wonderful to be in Institut Callot. In those early days, that is, I'm talking about the 90s, it was without exaggeration, the center of the spine universe. Everyone was excited about the revolutionary new concept of correcting spinal deformities, not just in the coronal plane, but also restoring the sagittal alignment. On my return to India, I performed the first correction of adolescent idiopathic scoliosis with Cottrell-Dubusse instrumentation. When I presented my experience with CD instrumentation, it was met with more than a fair bit of pushback, not unlike what non-fusion is facing today.
And there is some controversy about it, but it seems as if as more data is published, more research is being published as well. It seems to be very, very interesting. And we're going to talk a little bit about ASC as we go along as well. But
yes, sure.
Initially, I wanted to touch on the fact that there seems to be only a small percentage of spine surgeons that are comfortable with anterior approach, which is all about what you need the skills for in terms of performing DBT or ASC, any kind of anterior approach correction. Can you talk a little bit, because you have about 20 plus years experience with anterior approach, can you talk a little bit about how that expertise developed and why you continue to with that?
Yeah, so, you know, spinal tuberculosis, even today, is endemic in India. But when I started off as a spine surgeon, this is a long time back, it was perhaps one of the commonest spine ailments one encountered in practice. And tuberculous infection primarily destroys the anterior portion of the spine. And as a spine surgeon, addressing this through various anterior approaches to the spine gave me a thorough grounding, knowledge, and comfort to work on the front of the spine. I returned back to Europe to do a fellowship and train under the legendary Professor Jürgen Harms in Germany. This great man, who I consider my mentor, taught me a lot and trained me to master anterior techniques of deformity correction, among other things that he taught me. While most surgeons in the last 2 decades exclusively use the posterior approach to correct deformity, I belong to a small band of committed surgeons that even to this day employ the anterior approach to correct specific deformities. We firmly believe the distinct advantages the anterior approach gives us: better correction, minimal blood loss, saving levels. So that has been the key behind my training as an anterior spine surgeon.
Now, a question I always have, or with respect to tethering surgeries, is that there seem to be a couple of different major approaches for the thoracic area. There's with VBT, more immature spines. There seems to be more of a minimally invasive thoracoscopic anterior approach versus a mini open approach for ASC. Can you talk about the two and why you tend to move towards more of a mini open approach?
So I often get asked if I would do these surgeries endoscopically or mini open. I emphatically can say endoscopic surgery offers no major advantages whatsoever on the standard mini open approach. To my mind, it makes the procedure much longer. You have to keep the lungs collapsed for a longer time, significantly increase fluoro time perhaps, and most importantly, you cannot perform corrective maneuvers. And of course, you cannot do the lumbar curves. So if you want to extend the indications for non-fusion surgery, endoscopic approach would put certain limitations, I would think.
Okay. Now, sometimes I hear from surgeons that with a larger incision with the mini open in the thoracic region, there seems to be some research indicating that there might be more long-term pulmonary deficit, for instance, with a larger thoracotomy, correct? Have you seen that to be the case, or do you find that
So, Derek, in my over 20 years experience of doing anterior surgery, I haven't seen any child having long-term sequelae from the anterior approach. In fact, this has been proved by many studies now. And after the first 6 months or so, their lung function is as good or better than any of the children undergoing posterior spinal fusion, for example.
Okay. Well, I'm kind of referring to the mini open versus the minimally invasive thoracoscopic approach. Do you see any difference in terms of lung function long-term between those two approaches?
I don't. But then I have really not trained on the endoscopic. I only perceive that it could have limitations if one wants to do correction, as we will discuss perhaps about what VBT is all about and what correction is all about.
Now, you also touched on the fact that with the mini open, it allows you to make greater corrections versus endoscopic approach. Can you talk about that a little bit?
Yes. So you see, I always believe that this technique is not just for tethering. It is to correct. And if one wants to perform corrective maneuvers, then I go back to the techniques I used when I did anterior surgery. When I want to derotate the spine, when I want to correct the coronal deformity, I would prefer the mini open approaches where I can put these correcting tools on the vertebrae and exert the necessary forces to achieve that correction.
So the mini open approach allows you to have more space in terms of basically, correct? Okay.
Yes.
Doctor, when was your first exposure to non-fusion surgery, and why did you decide to start performing tethering?
So I always had a preference for techniques with which I could restore or control mobility. In fact, way back in 2006, I performed the first total lumbar disc replacement in India. This was a Charité, and it was US FDA approved back then. So it was very natural for me to segue into non-fusion surgery, bolstered over also by my over 2 decades long experience with traditional anterior surgery. Dr. Randy Betts had a very, very important role to play in this. We used to meet frequently at spine conferences. I have immense respect for Randy's knowledge, experience, and innovative ideas. I also visited him several times when he was professor at Shriners. Back in 2007, he introduced me to the precursor of the present day non-fusion scoliosis surgery, the use of the shape memory alloy staples to growth modulate deformity. I have to say, I learned a lot from Randy.
Mm-hmm. He's extremely well respected around the world for sure.
Oh, yes.
Now, with respect to tethering, can you talk about how many of these procedures you've done? Because I know you've been doing tethering for about the last 3 years, correct?
Yes, a little over 3 years.
Mm-hmm.
I must have been extremely satisfied with the outcomes. Our oldest patient to date is a girl aged 24, and the youngest was 7.5 at the time of surgery. So we have done kids in between this age range. We have had no cord breakages or screw loosening. Also, we haven't had any short-term operative issues with regard to the approach.
Do you roughly know how many immature spines you've done and how many mature spines you've done in terms of numbers?
We haven't, I would have to look back in the data, but I would say the immature spines would be about 30% and the mature spines would be about the rest of the curves that we have done.
Okay.
So more of the mature spines and maybe a limited experience with the immature spines.
Do you know roughly the total number you've done?
We have done around 50 to date. And during, of course, the last year, our practice was almost at a standstill and most of our patients could not reach us. And only now they have started coming back to us.
Now, you bring up a really interesting stat in terms of, with roughly 50 tethers over 3 years, you've had 0 tether breaks, because it seems to vary tremendously in terms of tether ruptures with surgeons, ranging maybe from 15% to almost 50% tether breakage.
Yes.
What makes you different in terms of why you think you had no tether breaks to this point?
I don't know, but we have a standard technique, and we use the tether to correct, and we have been very aggressive with our corrections. However, to date, we haven't had. Maybe our patients are smaller Indian patients. I don't know. To date, we have used in very few patients the double tether in the lumbar spine. In fact, we have done most of our patients using a single cord. So, but yet we haven't had to date seen any children with breakages.
Maybe we can talk a little bit about your parameters for immature and mature spines in terms of for tethering. Can you discuss that?
So as in anterior deformity surgery, the indications for me to use non-fusion are lumbar curves, thoracolumbar curves, that is the Lenke 5s, double curves, that is the Lenke type 3 and type 6, the typical thoracic curves, that is the Lenke 1s. For the immature spines, we consider non-fusion an option, provided the curves are less than 50-degree cob, with greater than 50% flexibility. However, in the mature children, we have done curves measuring even up to 80-degree cob. My case selection is largely based on my experience as an anterior deformity surgeon. It is not the magnitude of the curve. In fact, we have done over 80-degree cob, as I mentioned. It is their flexibility that is the key for me to decide. If they are flexible, then I will consider non-fusion. I assess this flexibility not just by bend films, but by awake traction films, which I have been using right from my early fellowship days at Institute Cologne.
Now, you mentioned you do awake spine, awake traction x-rays.
Yes.
How is that done? The patient is supine, their traction from neck and waist. Can you describe that a little bit?
So the guys sitting at the back, they are my team members. They are my spine fellows. So they will go and do these traction. We just put a simple lumbar belt traction support on the lumbar area, and then a collar on the neck with something to pull on, and that's it. And two of my guys will pull from either end and tell the child to relax, and we would get the picture showing the curve flexibility, which is better, in my view, compared to bend films.
I kind of agree with you, because I find that when you traction a spine, it gives you a much better idea, because you're just taking pressure off the disc, you're taking pressure off the posterior elements as well.
Oh, absolutely. Absolutely. Yes.
For your larger curves, because you mentioned that you've done as high as cob angle as 80 degrees.
Yes.
Right. Was that because that particular patient had a tremendous amount of flexibility left?
Oh, yes, absolutely. You hit the nail on the head. They were flexible. If they were not flexible, I would have reluctantly fused them. But they were flexible, and the traction films demonstrated that for me. So that's when I could confidently tell the parents, this is something we can, and they came prepared for non-fusion. So I could do it for the child.
Just for clarification, so let's say you have a patient that on bending films bends to, maybe they have a 50-degree curve and they bend to 30 degrees on bending films. Do you typically see more correction when you do the traction x-rays than that?
Yes, we do. And I am firmly convinced that every deformity surgeon should use a traction film to plan his correction, whether non-fusion or fusion.
Based upon that, because from talking to many spine surgeons who do tethering, and they have, for instance, a 50-degree curve, and the patient will correct to say 25 degrees on bending films, that typically seems to be the type of correction they see on the first standing x-ray. Maybe to 25 degrees, right? Because that's
maybe a little more if you're good and aggressive with your correction.
Okay.
Maybe a little more.
So if you do a traction x-ray, and maybe you see that on a traction x-ray, the spine is flexible to say 20 degrees.
Yes.
Do you typically know from that how much you can push the tethering in terms of tension?
Oh yes, absolutely, absolutely, and that helps me to even and the parents and the children, when they look at the x-ray, the traction films, I can convey to them how much correction we will get with the non-fusion.
Okay.
Yes, and they get convinced better.
Okay. Now, in terms of more mature spines, I think you said that you look for flexibility at least 50%, correct?
Yes,
Okay.
absolutely. Yes.
Okay. And as you know, on average, as the spine ages, you go from 14 to 24. You typically see the spine starting to stiffen, correct? Okay. Now,
That's true.
with the more mature spines, some spine surgeons will look to increase the flexibility even more so they can have greater correction in terms of
Yes.
doing perhaps a disc release, anterior longitudinal ligament release. Do you also do that?
So I do use disc releases. I do not do the aggressive disc excisions like what I would do if I was doing a fusion surgery. But I would do a disc release. And to date, I have used disc releases only in the thoracic spine. I have not performed any in the lumbar spine as yet.
Do you ever see yourself doing any disc releases in the lumbar spine if it's a very stiff curve?
If it is a very stiff curve, I still would think that they do not fall in my ideal indications for non-fusion.
Now, in terms of the type of disc release you do, because with surgeons, there seems to be a bit of a spectrum. So a disc release for one surgeon might be just a small incision, longitudinal incision, and with others, it might be anterior longitudinal ligament release. And for others, it might be removal of the nucleus of the disc. Where do you fall in terms of that spectrum?
So I would do, I think I would do just a release, perhaps including the anterior longitudinal ligament, but I would not go to the extent of completely removing the nucleus pulposus aggressively or curating the end plates. I would not go to that extent, but I would do a release if there is a significant rotation and I want to get a little better rotational correction.
Is the disc release more of a consideration for greater rotation or lack of flexibility, or is it a combination of both in your
combination of both, I would think.
Right.
Yes.
Now, in terms of your more adult tethering surgeries, what is most critical for success? Is it the spine flexibility? Is it the lack of degeneration to other elements like the discs and to the posterior elements? Do you look for as clean a spine as possible?
I certainly would. Mm-hmm. If I have to consider surgery in an older population, I would like those discs to be as pristine as possible. If they are significantly degenerated, in my view, it is better to go back to fusion surgery.
If the discs are not in the best shape, you would suspect that there's already too much degeneration there. Am I putting words? And in that case, if you do tethering, do you anticipate that the disc just won't respond properly, or?
Yes, and maybe I'm not sure if we would get a good correction. And tethering, and I don't want to call it tethering, non-fusion is all about correction. If you do not get, if you're just stabilizing the deformity without significant correction, then I think that procedure is likely to fail. It's not going to work.
There is a little bit of a controversy regarding tethering more mature spines, because the whole concept of VBT is for immature spines, bone growth modulation, right?
Yes.
So from your perspective, why do you think this form of non-fusion correction is appropriate for more mature spines with no growth remaining?
I would be very selective in the older population, and I would think of performing performing the non-fusion surgery only if they have a kind of one of those neglected scoliosis, AIS deformities. I would think of, and if they are flexible as per my parameters. if they have flexibility and they have a neglected AIS deformity and their discs are pristine, relatively pristine, I may consider in the older population.
All right.
In fact, Derek, we may be having a lady coming in from your country. She has a double curve, which perhaps was neglected in her younger age. And if she is flexible as we do our traction films and we find good correctability, we will consider non-fusion for her.
Part of the controversy with respect to more mature spines is that since there's no bone growth modulation and there's no change to the vertebra, right? There might be some tissue modulation once the spine is corrected. Do you see that as the important variable in terms of holding corrections in mature spines, perhaps once tethers break?
I think if after say 3 to 4 years there is a tether breakage, I don't think it would be of great consequence. However, we have seen, for example, when rods break in posterior spinal fusion, patients often end up having a fair amount of pain, not just loss of correction. This perhaps, our patients who are undergoing non-fusion surgery may not have pain as the posterior fusion group would have.
In terms of more mature spines as well, let's say you have a 50-degree curve or 60-degree curve, the spine is flexible, the discs are pristine, and you corrected the flexibility, let's say 25 degrees, 50%. Do you find that there's a minimum correction that you have to achieve in terms of being able to hold that spine? And if you know what I'm trying to say.
Oh, yes, absolutely. I think we have to look at how much correction we can get. And if that correction is you know, on our preoperative assessment of traction films, bend films is good, perhaps then we should undertake the non-fusion approach. Otherwise, if there is not much correction, not much flexibility, I would not venture into the non-fusion area.
Backtrack a little bit in terms of when you do disc releases for mainly the thoracic spine.
Yes.
Do you tend to just release at the apex discs or?
At the apex, only at the apex.
Okay. So you don't typically do maybe 2, 3, 4, 5, 6 releases if it's only at the apex, maybe 1 or 2?
Yeah, maybe 3. Yes, okay. 3. You know, the apical disc, the disc above, the disc below.
Now, I know you're always very, very conscious of the sagittal curve.
Yes.
Right. And as you know, with scoliosis, it tends to be more of a RASO effect, relative anterior scoliosis overgrowth issue, where the thoracic spine or whatever part of the spine, but mainly thoracic, goes into hypokyphosis and often into lordosis, right?
Yes, yes.
And I'm sure that's why you enjoy the anterior fusion technique, because it helps so much with the correction, right?
Absolutely, yes.
Now, with respect to using non-fusion techniques like tethering, I know you don't like that term, but do you find that you get much correction in the sagittal plane?
In the patients we have operated till date, we have seen a good sagittal restoration, both in the lumbar spine as well as in the thoracic. So it works, to my mind, it works like the standard anterior rod fixation technique, except that we are not fusing it.
Have you noticed as well, sometimes if it's a very stiff hypokyphosis, flat back, or lordosis, right?
Yes.
And order to get that forward flexion, that bend, I assume the disc release and maybe anterior ligament release is appropriate. Do you find that
Yes.
the case in those cases?
Yes, absolutely. Those would help to get the to restore a good sagittal profile, certainly.
Okay. Now, I'd also love to talk a little bit about your forte, which is anterior fusion.
Yes.
If you don't mind.
Yes.
Because it seems that it's similar to the access you are able to get to the anterior spine. Same as tethering, right? In terms of,
yes,
because it seems that it's difficult because of structures, shoulder blades to get above T4, maybe possibly T3 in certain instances. In terms of anterior fusion surgery, do you try to stay more in the thoracolumbar region for those kind of corrections, or what is the levels you can possibly fuse?
It's an excellent question. So the upper vertebra that I would fix, fusion or non-fusion, would ideally be D5, not higher. I have noticed that the vertebrae become very small. The fixation is very, very tenuous. You really do not get any fixation in the small vertebrae about in fact, D4, D3 are very, very small. And you really can't get a good screw purchase there. So even with my anterior fusion or non-fusion surgery, I like if the curve stops at D5, and even better if it stops at D6.
Okay, that's very interesting. Do you think that sometimes too many surgeons try to push the tether too high and as a result risks, pull screw out, or it's pointless at that point, at that level?
Yes, I mean, from my experience with fusion surgery, I would not venture to put a tether higher than D5.
And how low would you go with anterior fusion?
So we have gone up to L5.
Oh, okay.
Yes.
Pretty fascinating, because from what I've been researching, it seems to be more of a thoracolumbar sweet spot from what I've been looking at, but it's very fascinating that you go so high to low.
Yes, we have fixed some of our lumbar curves right down to L5.
Okay.
Yes.
Now, I wanted to ask you about your global perspective, because you're in Chennai, India. You trained in France and in Germany, and you've been to conferences, and you have experience in Asia and in North America as well. Do you see any particular different points of view in terms of even anterior fusion and tethering with respect to those different regions of the world?
Yes, I have seen that most of the American surgeons prefer to do linky ones. I think the trend there has been to growth modulate, use this technique as a tether in the North American, in US and Canada. But however, in Europe, the surgeons there are more comfortable with the anterior approach, and they have been doing double curves. They have been fixing up to L3 and L4. And I have seen there has been a greater enthusiasm in Europe for this new technique. However, in Asia, I see only a few centers that have picked up this technique. In India, in fact, I'm the only surgeon who's performing non-fusion surgery.
Do you expect non-fusion tethering surgery to grow and grow? But I guess the limiting factor is if the surgeon is comfortable with the anterior approach, or if they have to bring in another surgeon to assist, correct?
Yes, that becomes an issue. And I think that is one of the primary reasons why the last 2 decades, there was a general tendency to perform posterior spinal fusion for our children, because surgeons were A, not familiar with the anterior approach, and B, they did not want an access surgeon. And so there was, and also the pedicular screw fixations allowed excellent corrections, which could be achieved. So I guess all of this led to a movement away from anterior surgery.
Would you say that there's a higher percentage of surgeons in Europe and in India versus North America who do anterior approach?
I don't know about India, but certainly I think the training in Europe is more comprehensive, and most spine surgeons have a fair degree of comfort in anterior surgery.
Okay,
that's my experience with when I used to do my fellowships there.
Now you mentioned that you really prefer the anterior approach in terms of fusion versus posterior approach, and
for certain curves.
Can you expand on that a little bit?
So typically these are the large thoracolumbar curves, the lumbar curves, and we have done it in the Lenke 1, the classical thoracic curves as well, where we can limit it to the distal fusion could stop at L1 or D12, while if you were to do it from the back, often you had to go a level or two lower. So saving levels was a very important benefit from anterior surgery. Besides the fact that the blood loss is almost negligible, and the patients are very comfortable after the anterior surgery.
When you do the anterior surgery, do you completely remove the disc, and you also resect the ALL? Is that correct?
Yes, completely. Yes.
Okay. If you look into your crystal ball and you're looking into the future, where do you see scoliosis treatment surgery heading in the next 5, 10, and maybe 20 years?
So I do believe non-fusion anterior scoliosis surgery is a game changer. For over 70 years, we have been performing posterior spinal fusion. I call the procedure regional iatrogenic ankylosis. It is essentially not physiological, the fusion surgery. However, it will continue to be the gold standard for some more years to come. Non-fusion will definitely have a place in deformity surgery and will be adopted by more surgeons across the world as its undoubted benefits over standard surgery become more clear. I, for one, given a choice, would prefer not to strip the paraspinal muscles to fix a 70-degree Cobb Lenke 5, right from L5 to the lower thoracic spine. In a young girl who would very much like to continue her gymnastics or dancing and other activities. I do, however, observe a certain amount of reluctance and pushback. Some months back, we saw an article in a leading orthopedic journal showing the novel technique, that is the non-fusion, in somewhat poor light. And the editor of the journal, based on this one article, rushed to comment, is the tethering juice worth the squeeze in AIS? So I think as experience builds up with the new technique, it will clear the air. Also, over the next 10, 20 years, the technology will evolve, improve. There will be newer materials that will be available for making sure that the cords don't rupture. To conclude, I think non-fusion surgery has a great future.
I do too. That's why I went out and started interviewing all these tethering surgeons. It's fascinating. As you know, my son has also been.
I read about it. All
right. Now,
I hope he's doing well.
Yes, it's it's just pretty fascinating because I know he has a thoracolumbar curve, and you know the other option was fusion from T4 to L4, and I'm going, I don't think so. There must be another alternative, right? So
Oh, yes.
and it's just my hope that I can bring information directly from the experts, from the surgeons who have firsthand experience, so parents and patients can be fully informed and make their own decisions.
We in India now, I get patients from all across and inquiries from other countries because they don't want their child to undergo a standard fusion surgery. They are worried how it will impact. You know, we have had children who are prodigies at dancing and prodigies in gymnastics, equestrian sport, and they don't want their double curves fused. They think that would restrict their level of activities. And I think this is helping them live their life fully and achieve everything that they want. The young girls are very, very happy. The little girls who come to us.
Since we're on that topic, do you put any restrictions on activity afterwards? Like if you're a prodigy dancer and you know there's going to be a lot of movement, torsion, or do you just say, go right back to what you were doing?
So from our experience with anterior surgery, we were a little conservative while allowing these children to do all their activities. Most of them were told, at least for 3 months, restrict yourself. But just the other day, we had a child who had a Lenke 5 curve measuring around 70 degrees. 5 days after the surgery, she comes in to our clinic and she is able to do a small dance for us. She was a prodigy dancer and she was able to do it 5 days after the surgery. So I don't know, but I think we would still like them to take it easy for a little while, at least for 6 to 8 weeks.
Okay. Now,
and of course, no contact sport during that time.
Since you've had no tether breaks, have you had any revisions in terms of overcorrections for your more immature patients, or zero?
None as yet, Derek. None as yet. But we'll keep our fingers crossed. We need to follow up all these children. You see, the pandemic also restricted movement, and I guess we will see our early patients now, and we will be in touch if there is something happening.
Okay. A couple more other questions. Do you currently use Globus or Zimmer? What's the instrumentation? What do you use?
So I have always used the Globus. I used the Zimmer, which was originally meant as a non-fusion option for posterior surgery. I never had the option to use it anteriorly. And I've seen the Globus instrumentation evolve over the years, and it's now very, very good and very surgeon friendly. And it allows us to do all those maneuvers to correct and, to straighten the spine. And the tether is a very simple one to use. I believe there is a school, there is a group of surgeons in the US who use a flat tether. I don't know about that. I prefer the cylindrical tether. That's the cylindrical cord.
Do you know if if Globus is I heard rumors that Globus was coming out with a new tether last summer, but perhaps the pandemic slowed that release down. Do you know anything about that at all?
So before the pandemic, I was in the US and we were working on improving the cord and everything. But this last year has been like a blackout, and it's only when we start traveling that we will know what the new things that are in the pipeline.
For international patients who are interested in reaching out to you, what's the process in terms of once you accept them as a patient, what happens? How long do you anticipate the stay at the hospital, accommodations, that type of thing? How does that work?
So I work out of Apollo hospitals. The Apollo hospital chain is one of the largest in this part of the world. And they have an excellent international patient service. So the moment a patient gets in touch with me, I put the patient in touch with the international office, and they make it seamless right from the point that they board in the country where they are starting from, to when they land, to when they get to the hospital, and their stay. Everything is taken care of by the International Patients Division. And this is another thing that I would like to tell you, Derek. The surgery is much cheaper here in India compared to other centers, especially in your country.
Actually, what are your fees for it depends on length of the tether? How do you figure out pricing?
No. We have like almost like a fixed billing for the patient. But the important thing that I would like to tell you is that the patients, if they undergo a surgery in your country, I don't know how much. It's like 200,000 or
in the US, yes.
Yes, so it is, I can say it is a minimum, a bare fraction of that in India. And it's the same implants, the same technology that we use. And our hospitals are very well equipped to treat all these patients.
Excellent. All right. Doctor, is there any closing remarks you'd like to talk about before we terminate the interview here?
So I think non-fusion will have a great future. I think it will be the technique of the future. We will continue to fuse some of our scoliosis, but there will be a group of patients who will be ideally suited for non-fusion surgery. And as more experience is, more surgeons get experience, and as surgeons interact with one another, these things will become more clear, and we will know which are the ideal curves that are, what is ideally suited for non-fusion surgery, and the outcomes would have to be compared with standard fusion surgery over a medium and long term. I think we will have some exciting times to look forward to.
I think so too, because it seems that this field is changing month by month.
Oh yes.
In terms of the data that's coming out, and initially with tethering, the parameters were quite wide. Then
yes.
They started to narrow. Then they're
yes.
expanding again. Do you find that to be the case?
Yes. I would say I am aggressive about the use of the tether, but at the same time, I have my very strict indications for tethering, for non-fusion. I have very strict indications. I will not venture out of that and try to use non-fusion unless I see the long-term experiences of the more experienced surgeons.
Well, I find that this experienced surgeons who do tethering are very, they're looking for patients who are quite knowledgeable about this technique, because they're already pre-educated in terms of the pluses and minuses. Do you find that it's much easier to talk to patients who are knowledgeable versus those who just don't know much about it?
It's amazing how much information patients and their parents come already prepared with. It's amazing. They already have been in touch. They already been in groups. and they already have a lot of knowledge of the technique. So they ask very, very pertinent and specific questions. So it's very comfortable to interact with well-informed parents with a child with scoliosis.
Excellent. Okay. Thank you so much, doctor, for giving us your time. And it was a pleasure to talk to you.
It's a pleasure, Derek. Pleasure, Derek.
All right. I'll have a good morning and you can have a great evening.
Thank you very much. Bye-bye. Good night.